Good evening. Thank you all for joining me tonight. Why are we here? Lung cancer is the #2 cancer in both African American men and women. African Americans are at increased risk of menthol cigarettes and cigar use. There are increased death rates from tobacco-related causes and increased exposure to secondhand smoke in the African American community. We've seen increases in e-cigarettes of 135% in our high school students from 2017 to 2019. And lastly, we know smoking increases heart disease, cancer, and strokes. So we're here tonight to talk about tobacco prevention. Again, welcome to the Delta Research and Educational Foundation Research Matters for All of Us session on cancer prevention via tobacco. This is the leadership group for the All of Us research program as a part of DREF. They've been working diligently to ensure that we continue our education across the United States. These are the 12 cities, 12 beautiful cities that have been chosen to educate the African American community on the importance of biomedical research and their participation in it. I am Yvonne Collins, your Chicago citywide coordinator, and I again thank you for joining me this evening. The Delta Research and Educational Foundation was established in 1967 as a major nonprofit organization with the primary goal of supporting African American women and their families. As part of the Research Matters for All of Us campaign, we have been engaged via the NIH to create awareness, encourage health and wellness in the African American community. Let's watch this video on our participation.
In 1967, Delta Sigma Theta Sorority Incorporated established the Delta Research and Educational Foundation as a public charity supporting scholastic achievement, public service programs, and research initiatives focused upon African American women and their families. Today, DREF remains strong, vibrant, and poised to meet 21st century challenges with the same unwavering spirit and dedication the sorority originally envisioned. The charge to realize social and economic equality for future generations of African American women continues as the guiding principle. Since 2017, DREF has received funding from the National Institutes of Health to continue its role as a national community engagement partner to promote the All of Us research program through a community awareness campaign that informs African Americans and minorities about the importance of understanding and participating in biomedical research. The National Health Initiative, conducted by the Delta Research and Educational Foundation in collaboration with Delta Sigma Theta Sorority Incorporated and the National Council of Negro Women, is entitled Research Matters, Creating Possibilities to Achieve Health and Wellness for All of Us. The objectives are to engage, educate, and ultimately enroll African Americans in the National Institutes of Health All of Us 1 in a Million campaign, a national database primarily comprised of diverse and traditionally underrepresented populations. The mission of the All of Us research program is simple. It is to speed up health research and medical breakthroughs by asking 1 million people to lead the way to provide the types of information that can help create individualized prevention, treatment, and care for all of us. The All of Us research program is a part of the Precision Medicine Initiative created during President Obama's administration. Precision medicine is healthcare that is based on you as an individual. It takes into account factors like where you live, what you do, and your family health history. Precision medicine's goal is to be able to tell people the best ways to stay healthy. If someone does get sick, precision medicine may help healthcare teams find the treatment that will work best. This will help give healthcare providers the information they need to make tailored recommendations relevant to people of different backgrounds, ages, or geographic regions. African Americans continue to have some of the highest incidence, prevalence, and mortality rates from chronic diseases such as cardiovascular disease, diabetes, obesity, hypertension, mental health, and HIV/AIDS. Yet we comprise only 5% of clinical trials participants in America. Our focus and objective is to create awareness about how research matters in closing the health disparities gap. DREF seeks the assistance of national organizations, local chapters, sections, community leaders, and organizations to make the All of Us research program a successful endeavor. The influence, leadership, and participation of the aforementioned groups are needed to assist in promoting this groundbreaking opportunity. Individuals, groups, and organizations are welcome to assist with conducting and/or identifying outreach activities. Training, materials, and monetary resources may be available to support groups and organizations with approved collaborations. Please send an email of interest to researchmatters@deltafoundation.net outlining upcoming activities and events in which the All of Us research program can be included. For more information, please visit www.joinallofus.org/DREF.
So there are 12 citywide coordinators that work to engage the community for the NIH All of Us campaign. Beginning September of 2020, our events have been virtual, but we do 2 monthly Delta Research and Educational Research Matters for All of Us activities with the goal of increasing education, partnerships, and collaboration with local community organizations. The NIH All of Us research program is really historic. It's a longitudinal study with the aim to gather 1 million diverse groups of participants to help accelerate medical advances. Let's listen to precision medicine from President
Precision
Obama.
Medicine initiative to bring us closer to curing diseases like cancer and diabetes, and to give all of us access to the personalized information we need to keep ourselves and our families healthier.
Let's take a deeper look a little bit at what this means for research participants.
My name is Janelle Johnson. I'm a biologist in the Laboratory of Neurogenetics for the National Institute on Aging within the National Institutes of Health.
Dr. Janelle Johnson has long had an interest in neuroscience, especially in neurodegenerative diseases.
My focus is on the genetics of neuromuscular diseases, in particular ALS, but I also study neurodegenerative diseases such as Alzheimer's and Parkinson's disease.
Developing treatments for these diseases, treatments that are geared to the individual person, is also one of Dr. Johnson's goals.
Research has advanced to the point where personalized medicine has become a reality. And when I say personalized medicine, I mean that specific traits that you might have are more easily targeted by particular drugs. As researchers, we can target those drugs and find the best possible solutions for your diseases.
To find these solutions, scientists need to conduct clinical trials, research studies with volunteers, to see which treatments are safe and effective, and for whom.
If African Americans participate in research studies, they have the opportunity to treat or ultimately cure diseases. If not, we won't be sure if the current studies will apply to them.
Dr. Johnson says that more African Americans are needed for these studies, but there is sometimes reluctance to participate in clinical trials.
African Americans are often fearful of participating in clinical trials, and I think this largely has to do with the Tuskegee syphilis study, which lasted for about 40 years, so a lot of people were impacted by that.
However, today protections are in place that make participating in a study a very safe experience.
I think that African Americans can take time to educate themselves and others about the clinical trials that exist and the informed consent process.
So precision medicine, as you just heard, is really an emerging approach. It takes an individual, it looks at your family, it looks at your environment, it looks at what you eat, it looks at your biology, and it works to identify specific targets that are effective for the disease that you have. We've seen this over the last probably 8 to 10 years sort of break rampant in oncology. We can now take a tumor and get down to the level of exactly what genetic abnormality caused that tumor. And now we have medications that can focus on that abnormality. So it has been an absolutely radical shift in how we treat patients in oncology. As part of the research program, we also have various healthcare provider organizations that participate with us. And All of Us Illinois has 5 participants. And we have tonight Nicole Hunt, who is a research assistant with the Northwestern University All of Us program. And she's going to talk a little bit about what to expect when you're on site. Nicole?
Hello. Thank you, Dr. Collins, for that really wonderful presentation and introduction. As Dr. Collins said, my name is Nicole. I'm from the All of Us Research Program and work in community outreach. And we appreciate you taking the time to be with us tonight and to learn a little bit more about the program. So I'm going to share some of the next steps that you can take for enrollment. The next slide, please. First, participation is made up of both an online and an in-person portion. So what does this mean? First, participants are given a list of nearby organizations to partner with. In Illinois, you can choose to partner with multiple sites. And when you pair with a site, you're given the opportunity to schedule an in-person visit. And that is where you will first be asked to complete. You'll come in for, that portion will take about 30 minutes and it'll include your physical measurements as well as your biosample collection. And then you'll also do an online portion where you'll download the All of Us app on your phone or go to the website at joinallofus.org. There you'll create your account, also known as your participant portal, and that will be your digital space for the participant experience. Participants will consent to participate, and it will include a series of screens and videos explaining the program and participant rights. Consent documents need to be read and signed. And then next you'll complete a series of surveys. Survey completion is what will provide researchers with the understanding of your life and environment, like how you exercise and what you eat. Surveys are an important part of staying connected with participants and hearing about the changes in your life over time. So if you have any further questions for me regarding how to join or are interested in learning more about what participation entails, please feel free to contact us using the information that Dr. Collins has shown, and I will also put it in the chat here. And we hope to see some of you at the Participant Center soon. Thank you so much, and I will hand it back to you, Dr. Collins.
Thank you so much, Nicole. As we prepare for the next portion of our agenda, you can see on the screen, these are 2 of the sites where you can go to gather additional information: www.joinallofus.org/DREF or researchmatters@deltafoundation.net. You can also like and share, we'd love it, any of our social media platforms, that is Facebook, Instagram, or Twitter. Again, my name is Yvonne Collins. I'm the Chicago Citywide Coordinator, and I'd like to thank you again for being here this evening. As we move to our featured speakers, I must read this disclaimer to you. The views and opinions expressed by the guest panelists and/or presenters do not reflect the views or opinions of the Delta Research and Educational Foundation. DREF Research Matters for All of Us, the NIH All of Us Research Program, or any of the organization affiliates. Thank you again, and I'm delighted to introduce our community partners for the evening: the Illinois Department of Public Health, the Illinois Tobacco Quitline, and the American Lung Association. Gail, I'm going to stop sharing and you can prepare to share your slides as I do your introduction. Gail Doe has been with the Illinois Department of Public Health since 1990. She has been the program manager of the Tobacco Control Program in the Division of Chronic Disease and Prevention since 2010. She oversees initiatives under the Center of Disease Control and Prevention, the National Tobacco Control Program, with state funding of local health departments, community-based health disparity initiatives, and the Illinois Tobacco Quitline, which we'll hear more about tonight. Ms. DeVito previously served as the program administrator in IDPH's AIDS HIV Prevention Center and in the Division of Government Affairs. She began her career in Illinois government with the Illinois General Assembly's Joint Committee on Administrative Rules. She has a background in public health policy development, strategic planning, administrative rule planning, rulemaking, and legislation. Thank you very much, Ms. DeVito, for being with us this evening.
Okay, and thank you, Dr. Collins. It took me, oops, I went too far. It took me all that time to share my slides. So I am happy to be here with you all this evening, and you can hear me. I want to make sure I'm not muted.
We can hear you well. Thank you.
Okay, thank you. So I am going to talk about tobacco prevention and control activities in Illinois. It says here tobacco prevention and control program, which is housed in IDPH, but really we could, we would not be able to do these activities without all of our partners and grantees. This is a statewide effort on the part of partners, grantees, and it's funded by IDPH. And we provide resources. We provide resources from the Centers for Disease Control and Prevention, Office on Smoking and Health, which partially funds our program, and it's partially state funded. So under these activities, we address the problems of youth and adult tobacco use and secondhand smoke exposure, the elimination of it, and youth prevention of tobacco use. Our strategies are aimed at reducing the burden of tobacco use among the Illinois population, and particularly among the high burden populations, the populations that experience a disproportionate burden of tobacco use. And we do this through tobacco control grants to all of the local health departments, and our largest grant to the American Lung Association for the operation of the Illinois Tobacco Quit Line. And you're going to hear a lot more about that after I'm finished. We also have we have a statewide partnership and local and regional coalitions, which I will touch on briefly later. But before I go on to any of our activities, it's necessary to talk about health equity in tobacco prevention and control, because this drives all of IDPH programs. We have a focus on health equity. All of our grantees are required to have a focus on health equity. And so that's where I want to start now. So in public health, health equity is the opportunity for everyone to reach their full health potential. No one should be prevented from achieving this potential because of their social position or any other of the social determinants of health, which are shown in this illustration. Health equity in tobacco prevention and control is the opportunity for all people to live a healthy, tobacco-free life, regardless of social determinants of health. And the factors here, I've shown some of the tobacco-related disparities and how they are created. Of course, the social determinants of health, tobacco industry influence. Dr. Collins mentioned menthol. African Americans have been targeted by the tobacco industry with menthol for more than, we go back 50 years. We go back to 1964 addressing this, but it goes back way further. And there are recent efforts to ban the tobacco industry, to stop tobacco industry's influence with menthol bans. There have been successful menthol bans in a few places like San Francisco, and FDA, the Federal Food and Drug Administration, announced a few months ago that they're working toward a menthol ban, but it'll be years before we see that. It's that kind of thing is better done at the local level, and then eventually the state and federal level will catch up with the local policies. So also a lack of tobacco control policies and laws. contribute to tobacco-related disparities. Illinois has strong tobacco control laws, and so does Chicago. And so then when you have the laws in place, lack of enforcement and compliance are factors that create a situation of inequity. And an example of this is when young people can buy cigarettes or vapes, really vaping vapes and e-cigarettes at a corner store because it's not being enforced and the tobacco retailer is not complying with it. So all of those things contribute to inequity in tobacco control, and our strategies are, the intent of our strategies is to influence that and help prevent it. Okay, so just a few other points about how health equity, how a lack of health equity in tobacco control creates worse health outcomes for people who are experiencing it, for minorities, for low income, low education, people with disabilities, and LGBT and other disproportionately impacted group populations. So you see that there's a higher density of tobacco retailers in low-income neighborhoods. This results in more youth exposure to just tobacco in general, and youth thinking it's a normal thing instead of thinking it's not a normal thing to see. So social norms. Tobacco product initiation or startup of tobacco use workers in the service industry and traditional blue-collar jobs are more likely to start smoking cigarettes at a younger age. So the earlier someone starts smoking, the more likely they are to stay addicted and have a harder time with cessation. Tobacco cessation, adults with less than a high school education have less success in quitting than those with a college education or greater. And tobacco-related mortality. People with a family income of less than $12,500 have higher lung cancer incidence than those with family income of $50,000 or more. And I could add to this, children. Well, I'm not going to add to the slide because I'll talk about that with a later slide. But also, okay, I'm going to change. So our program strategies to address the problems of tobacco control and the burden of tobacco control on disproportionately impacted populations. Our strategies center around adult and youth cessation, and I'm going to be leaving adult cessation to Lori Yonker for her presentation because she's really going to cover that in depth. Youth tobacco and e-cigarette vaping prevention and cessation too. Dr. Collins gave some data at the beginning, which I didn't bring. I was going to bring data, but then I didn't, and I'm glad I didn't because it would have been duplicative. So we do see that youth are using tobacco products less, cigarettes less, not really little cigars, they're still using them, but e-cigarettes have really, the use has expanded exponentially from, say, 2015 to 2018 and currently. So secondhand smoke elimination is one of our major objectives, and health equity crosscuts all strategy areas. These objectives are part of the National Tobacco Control Program, and all of the states and territories and Indian tribes are funded by CDC to do this tobacco control work. So I wouldn't want to talk about tobacco control and make it sound like, as I mentioned at the beginning, that IDPH was doing all of this work. It's done by grantees, coalitions, and partners. So the coalitions, they bring together individuals and organizations with diverse skills and expertise to address the issue of tobacco control in our instance. They work to build community support for policy change. I'll talk about policy change and tobacco control in the next few slides. And our coalitions work before anything can be introduced in a city council or a state legislature, the work is done at the ground level by the coalitions. And we strive at the state, regional, and local level for coalitions to be representative of the populations that are experiencing the burden of tobacco use. So our coalitions, we are constantly trying to recruit and retain membership, and our coalitions include representation from healthcare, academics, schools, both higher and K through 12, faith-based, youth serving, disabilities, organizations that serve people with disabilities, and then all of the demographic groups that experience the burden of tobacco use. So it is kind of a struggle because it's always the case where coalition members, where it's the same group that is always helping and doing the heavy lift for this kind of work, but we're constantly in the process of trying to find new members and replace members who have left to maintain that level of representation. So the first of our objective areas that I'm going to touch on is the elimination of secondhand smoke exposure. For that, we're lucky to have a comprehensive smoke-free air law, the Smoke-Free Illinois Act, and in Chicago they have the Clean Indoor Air Ordinance, which is identical to the Smoke-Free Illinois Act. Whenever a municipality has their own ordinance that's identical or stricter than the Smoke-Free Illinois Act, they enforce their own act. So it prohibits tobacco use, combustible tobacco use at all public places and places of employment. It's not just restaurants and bars, it's all workplaces and all public places. And enforcement is good in some areas of the state and it's not good in others. I think it's particularly good in Chicago. Unfortunately, well, statewide, it does not include e-cigarettes, but in a number of cities, including Chicago, it does include e-cigarettes. There's been a push to get it added to the statewide law, but it hasn't been successful so far. So other smoke-free policies that our primarily local health departments are working with their coalitions to build support and have these policies adopted in their communities are multi-unit housing. So multi-unit housing policies are generally done individually by property management companies, and the struggle is to get more affordable housing smoke-free because smoke travels through a lot, gets from unit to unit in a lot of ways, as you may know, through wiring, through like outlets and through ductwork and under doors. So you really can't have multi-unit housing that you can't keep smoke out of a smoke-free unit when there are people smoking in other units. And we receive calls all the time on our Smoke-Free Illinois hotline from people who are struggling with smoke infiltrating into their unit from a neighbor have a child with asthma and they have a lease, and there's no solution to it because it's not covered under the Smoke-Free Illinois Act, unless the landlord or the property management company adopts a smoke-free policy. This is already existing in HUD housing, all HUD housing, not Section 8, but Public Housing Authority since 2018, I think. So, so that was a really monumental step. But there are so many people who are suffering with smoke infiltrating into their dwelling unit, and they can't do anything about it. And that's why the local health departments are working with. They're working with landlords. They have toolkits. They have online toolkits. They hold meetings, and coalitions are helping to get this information out and help build support for these policies. There has been a lot of success. Close to 100 policies. The issue is the affordable housing, and we continue to work on this. This is part of our program every year, and we'll continue to have this as something that local health departments can select to work on under their grant. Outdoor smoke-free outdoor spaces, those are done as ordinances. We have, well, some of them are policies, but mostly they're ordinances through either a park district or a municipality, and we've had great success with those, close to 60 statewide, and they're not all the same level of rigor. You know, some of them have enforcement, some of them just say you can't smoke in the park. They're for parks, beaches, even places like farmers markets, outdoor music place festivals, that kind of thing. So there's a big range of outdoor smoke-free outdoor policies. But what's good about these policies is that when they're in places that children go to frequently with their parents, they're not going to see people smoking. They're not going to see tobacco litter. So that aspect enforces. It helps reinforce social norms about tobacco use not being a typical thing, instead of social norms about we see cigarette butts everywhere, you know, when we go to the park. And then smoke-free homes and cars, those are individual voluntary policies, and they're encouraged to help, even if the parents haven't quit smoking yet. At least they're not smoking around their children. The children are not they're not exposed to secondhand smoke, and they are not exposed to seeing people smoke. Okay. So then other areas of our strategies are on restrictions on tobacco retailers. In 2019, Illinois changed the law for sales of tobacco products from age 18 to age 21. And what's important here is that tobacco retail stores comply with the law and do not sell to youth. We've heard too many examples of youth being very easily able to buy tobacco products and not getting carded. So that's a health equity issue that the Tobacco 21 law is enforced under different federal funding, an FDA grant, and it all goes through the Illinois Department of Human Services. We provide education and some print materials for, and we work with the Illinois Department of Human Services, but we do not have any direct control in the compliance or in that law. Another area, and some of our local health departments are working on this in their communities. the reduction of tobacco retail store density. There's a graphic that CDC shows us at our national meeting sometimes where they're mapping of tobacco retail stores, and there are more of them than McDonald's. And it's hard to believe, but then you see it on a map. And I know Chicago Department of Public Health has done work and is still doing work on tobacco retail store density, but the reduction of it is something that will help reduce youth from starting tobacco use, because they won't be walking past retail stores on their way to school and in their neighborhoods, and they will not think of it as normal. They won't see those images. The more they see those images of tobacco, because basically tobacco advertising, the retail store is the main source of tobacco advertising, because tobacco TV advertising and everything was banned in the 70s, and so now the packaging and the store windows and just the wall of tobacco products, those are their main sources of advertising. So, and we saw that there's a higher concentration of retail tobacco stores in lower income neighborhoods. So that this is one of the more difficult things to get accomplished, because legislators see it as we're hurting small business, it's hurting small businesses, but it's helping, it's really going to help youth avoid becoming the next generation of smokers. So the other thing, and we've been seeing this in a few other places, but I know Chicago has an ordinance now that bans flavored e-liquids, and the ordinance was originally stronger and included menthol, and it was weakened because of that fear, that feeling on the part of city council members that this would hurt small businesses. But they're still working on it. We have a few other areas, one in Lake County, a few other, not too many, but a few, that are working on bans on sales of flavored e-cigarettes and vaping products and menthol. So flavors are meant to target youth, and menthol is meant to target African Americans, youth, young adults, college age, LGBTQ, and primarily, those are the primary. Really, menthol is, it has higher sales and higher usage all over, but primarily in those populations. So I have, okay, then youth prevention. We have a lot of our local health departments, about 25 this year, are working with schools or school districts on school prevention programs. And they have, they're doing vaping prevention or vaping prevention programs, education programs. Last year, some of them had to be done virtually. A few of them were done virtually. This year, they are able to go into the schools more. And so that's great. So, they do pre-tests, program, post-tests. So we would like to evaluate these programs and see how they work and how effective they are, because there are so many influences on youth from outside that we want to see how the school programs are working. But they're an absolute necessity, because of Dr. Collins talked about e-cigarette use, and here, we can see the increases in e-cigarette use. It was just the Surgeon General, Dr. Jerome Adams, in early 2019, issued a directive that made it an epidemic, the epidemic of youth e-cigarette, youth vaping. So this has been worked on across the country, and we have a multi-pronged approach to address this. And this is the prevention part. And then we have a cessation. And then here's some of the things about e-cigarettes that youth who smoke them, who use them, may be more likely to smoke regular cigarettes in the future and to stay addicted to nicotine. And it's a struggle to address this because a lot of young people think vapes do not contain nicotine and are not addictive. They're very misinformed about them. And so a lot of information has to be made available to convince them to change their thoughts about that. So then this is, so we knew when this epidemic was declared, and we saw the rising rates in Illinois. One thing is that our state plan in 2015 didn't even address e-cigarettes because we still had a very low rate. And then we had to change it as when we got to 2017 and 2018 because it had gone up to like 40% of high school seniors. So we, this program, My Life, My Quit, it's a youth tobacco cessation program that's been around since 2019. It was created to address that youth vaping epidemic. And this is now available in Illinois. It's the newest, kind of the newest thing in our arsenal in Illinois for, it says tobacco, but it's really vaping. And I put the website here, and I can, if I need to send you more information about it, I can. My Life, My Quit, it is operated by National Jewish Health, which is a, if you're not familiar with it, it's based in Denver, and it's a large healthcare institution that also provides the Quit Line service for about 15 states, maybe 15 to 18 states. And they also provide this, this service, My Life, My Quit, which there's a website for it, and it's primarily online. Youth can enroll online. They can text to enroll, and it's primarily done online and by texting, but it is also, they also have live telephone counselors that youth can talk to, but that isn't the primary mode of delivering the program. Primarily texting and online. And we are, you see it says Illinois Tobacco Quit Line. We're doing this through our Quit Line grant, and our Quit Line, Lori Yonker and I talked about what we could do for youth cessation, because we reduced the age for our Quit Line. It was 18, and we reduced it to, we made it available to 13 to 17-year-olds, but received very few calls. You really need something targeted to youth and tailored for them, and this is it. And so this is the first year we're doing it, and we are promoting it on all of the social media that youth are using, Instagram, Snapchat, TikTok. And then there are resources for parents and educators. And there's a link on the Illinois Tobacco Quit Line website for adults to find out more about it. But this page is directed at youth. So we're really excited and happy to have that, and hope that it will be very successful. It's already, we're getting the National Jewish Health provides us with reports every quarter, I think every month, and they are, we are seeing a lot of calls because of the social media promotion, and we hope we see a reduction in our youth vaping rates as a result of having this available. Okay, so I just wanted to talk for a minute. I think I touched on it, and the tobacco industry and media influence, particularly on youth, and with menthol, and so public health, health communications and media is, of course, we have minuscule budget in comparison what the tobacco industry spends, and but we do counter marketing to try to influence social norms about tobacco use. This is a part of our whole layered approach: the media, marketing, and the program. So the school programs alone wouldn't really be enough. We need to have youth see these images, and this public health media and communications. So, the idea is to influence social norms, the attitudes and beliefs that young people think that they won't they won't keep smoking, they won't become addicted. They think that they have to do it to fit in with their friends. All of those things that we all know about young people with tobacco use. And this counter marketing helps to dispel the myths about it, but we don't know the impact it has. It has an impact, especially we know that tobacco media has an impact, like the CDC ads, tips from former smokers. We know those really have an impact because we see the calls coming into our quit line when those are running. But those are primarily older people they're adults, and they're adults who are concerned about having a chronic disease, a tobacco-related chronic disease, or like that. But it is a little more difficult to reach youth. And tobacco advertising, it targets audiences with persuasive messages like the 60 years, 70 years of menthol ads that targeted African Americans by having people in there, attractive people looking like they were having a great time and with a cigarette. And it contributes to their image as this is who we are. We smoke. And it's the same thing that is a very strong belief and influence on LGBTQ and also people with disabilities. And I didn't mention people with mental health conditions. That's also a group that is heavily persuaded by these messages or identifies themselves as smokers. There's a lot of for behavioral health and disabilities, we have a lot of evidence about tobacco use and that it's accepted in the population, and those are part of our targeted populations. And I think that I think I should probably wind up and give Lori a chance to go to talk, because I'm trying to time myself to 20 minutes. But these are just some examples of youth exposure to e-cigarette advertising and how it's everywhere. So I'm not going to stay long on these. And and that's it. So I think that we're going to take questions at the end, and I will stop sharing my screen.
Thank you very much, Ms. DeVito. Lori, you can start to bring up your slides after, as I introduce you. So Lauren Yunker is the National Senior Director of the American Lung Association's Helpline. In addition, she serves as the director of the Illinois Tobacco Quit Line and has been with the organization 31 years and has managed the Quit Line for the past 3 years. Throughout her years, Lori has been responsible for the creation, development, promotion, and evaluation of core program services, including tobacco prevention, asthma, COPD, continuing education, and research. She has focused her efforts in managing the overall services of the Illinois Tobacco Quit Line. So I thought I would be remiss if we did not at least hear about our tobacco quit line and the impact that it's making on those populations that smoke. So Ms. Yonker, I'll turn it over to you. Thank you.
All right, thank you, Dr. Collins. And more importantly, I just want to thank you to learn more about your organization and what you do, and especially around research. So I will encourage, I will reach out because I'd like to make a connection, of course, with our national research program. I think there's a great collaborative there that we could all be working on. So I don't want to forget that. But good evening, everyone. I am Lori Yonker, the National Senior Director for our Lung Helpline and the Illinois Tobacco Quit Line. Really pleased to just take a few moments to kind of highlight kind of the impact of tobacco use and really talk a little more about the conditions that are impacted by this. And then to really focus in on the cessation side of really the work and what we're doing and in our partnership with the Illinois Department of Public Health and with the Illinois Tobacco Quit Line. I hope this is a service that each of you will want to promote and share with your colleagues and with your family and friends. So we'll just start off here. Oh, my screen might be frozen because I've had it up for a while. There we go. Thank you. So just a little bit about the American Lung Association. Of course, we are one of the leading organizations in working to save lives by improving lung health and preventing lung disease with a focus through research, education, and our advocacy efforts. Our work is focused in 4 strategic imperatives: to defeat lung cancer, to improve the air we breathe, to reduce the burden of lung disease on individuals and their families, and to eliminate tobacco use and tobacco-related diseases. Since we first began our work in tobacco control, we assisted in prompting the first Surgeon General's report. We've helped over 1 million tobacco users quit. We've served as a major backer of smoke-free air laws and continuously work to improve tobacco cessation coverage. It's also important to note that smoking is the leading cause of preventable disease and death in the US. Its use results in 480,000 premature deaths per year, and the cost the United States $300 billion in direct healthcare expenditures and lost productivity annually. Since 1964, 20 million deaths have been directly attributed to tobacco use. The users themselves are not the only ones impacted. Secondhand smoke is harmful to children and adults, and there is no risk-free level of exposure to secondhand smoke. Since 1964, 2.5 million lives have been lost due to secondhand smoke, and it is estimated that about 58 million non-smokers were exposed just in the recent years. And this is why clean indoor air policies are so very important in the work that we all do. Now I'd like to have a few slides to really just talk about some of the effects that our tobacco users face each day. So when we think about every puff, it's increasing our heart rate, it's increasing our breathing rate, it's constricting our blood vessels, and it's decreasing our oxygen carrying capacity in our blood. What are some of those short-term effects? Of course, lowering our lung function, the addiction to nicotine, the shortness of breath, the decrease in the sense of taste and smell that we all have, the increasing and resting heart rate, our skin appearing pale and unhealthy, of course, the bad breath, which we've all had known, and diminished capacity in sports and activities that we all want to participate in. Tobacco use also leads to disease and disability and harms nearly every organ in our body. And just to name a few, it's important to note that tobacco use is a chronic illness and it directly contributes to the numerous chronic diseases. More than 16 million Americans are living with a disease caused by tobacco use. And for every person who dies because of tobacco use, at least 30 people live with a serious tobacco-related illness. Smoking causes cancer, heart disease, stroke, lung diseases, diabetes, and chronic obstructive pulmonary disease, which also includes emphysema and chronic bronchitis. Tobacco isn't a drug that kills its users instantly. The tobacco industry's product cause chronic illness and disease, resulting in years and years of suffering. I placed this slide in here today. So for individuals who don't particularly know the cycle of addiction, when we think about whether it's the puff from a cigarette, a puff from a cigar, a puff from a vape, you know, and really what's happening. And so I kind of want to walk you through this. So the cigarette delivers nicotine to the brain in 7 to 10 seconds after the first puff. The nicotine acts on certain receptors in the brain, releasing the hormones and the neurotransmitters, which includes the dopamine and the norepinephrine and the serotonin. The smoker feels the pleasure, they have reduced tension, they have the appetite suppression and enhanced performance. So this is what's going through their minds as they take this and why they're continuing to do this. The nicotine accumulates in the body, and each additional puff, whether it's a cigarette or a vape, creates great tolerance. The brain's chemistry changes and the tolerance develops. The absence of that nicotine causes a withdrawal and the recovery symptoms. As the day goes on, the tobacco user needs more and more to relieve that withdrawal and recovery symptoms. Overnight, diffusion of nicotine throughout the body helps the tobacco user regain his or her sensitivity to nicotine, and the cycle continues on and on. So now let's look at how we want to be able to assist and help everyone as we can, as we look at the core beliefs regarding tobacco cessation. So we know that everyone can quit. We know you don't have to quit alone, that we know the number of times it can potentially take 1, 2, 3, sometimes even more in that quitting process. We know that every moment you don't use a form of tobacco is success. We look at that when we are working with our tobacco users each day that we connect, each call that we have, or each class that we host, and being able to know how successful they can be if they can just go minutes, if they can go hours, and then we go into our days. You had to learn how to smoke and use tobacco, so you have to learn how to quit. We need to give you those skill sets to assist in that process. We also know it takes most tobacco users several tries before they're able to quit for good. One of the core things is we know that one size doesn't fit all. So through the service we're going to talk about today with the Illinois Tobacco Quit Line, we have a form through working with tobacco cessation counselors. But we also know individuals like to try online programs. They like to work on their own. They like to have texting programs. So we know that we need to have multiple options for that tobacco user. We also know that combining medication like nicotine replacement therapy with a quit tobacco program even increases the results of success. And we also know, and we want our tobacco users, these are some of the models that we use with them so that they know the importance that if you slip, it is not the same as a relapse. And we talk about the difference between those two. I also wanted to kind of focus in a little bit about the stages of change and really what someone's going through when they are giving up what they are addicted to. So we've got this information. So our tobacco cessation philosophy is built on several key principles that are evidence-based and proven effective. And one of those principles is the trans-theoretical model, otherwise known as the stages of change. This model gauges where an individual may be in their willingness to lead their tobacco-free lifestyle. So when we look at our stages, we have our pre-contemplation. So we know we're not ready to quit within the next 6 months, something we might be thinking about. Contemplation is a person is aware that the problem exists and is seriously thinking about making that change and thinking about quitting. Preparation. So they're still using tobacco, but they intend to quit within the next 6 months. Then we have action. So we're dealing with a lot of feelings of anxiety. They don't want to slip or relapse, and they remain tobacco-free for at least 6 months. Then we have our maintenance, where we want to remain and stay tobacco-free, becoming a non-tobacco user, focusing in on the positives and finding alternatives. And then, of course, termination, no longer desirable and living a tobacco-free lifestyle. Our research literature states that in any given population of people who use tobacco, 40% are not ready to quit, 40% are thinking about quitting, and 20% are ready to quit. So we look at facilitating behavioral change. This is what we've, a lot of assumptions, I think many of us who are non-tobacco users, we would think that all tobacco users would be able to quit because we give them the insight. We can just make people see, and then they'll be able to make that change. You would think that we give them the knowledge, that people just know enough, and then they will make that change. That we give them the skills that they need. If we can't just teach people how to change, then they will do it. And then we have to give them a hard time a little bit. If we can just make people aware of those health consequences, they can make that change. But behavior change is not driven by education. It's driven by the motivation that they all have. And these are some of the skills that our cessation counselors are providing for callers who utilize the Illinois Tobacco Quit Line. And so I want to just take a few slides to talk about the benefits of quitting. So these can be core talking points that each of you can use as well when you're encouraging those your loved ones, your colleagues, and the importance of knowing that there are resources out there to assist them. So improving our health status and ultimately enhancing our quality of life, reducing the risk of premature death and can add as much as 10 years to our life expectancy, reducing the risk of so many health effects from our poor reproductive health outcomes, our cardiovascular disease, our chronic lung disease, and cancer. The benefits for the health of a pregnant woman and the fetuses and the babies, and also to reduce that financial burden that tobacco use places on people who use and from within the healthcare system and society. So let's look at, and I do apologize, I'm going to do this really quick because I needed to put this one first when I was building this program for you all. But the health benefits of quitting over time. So let's think of the short term and then look at our long term. So within minutes of somebody quitting, their heart rate drops. Within 24 hours, that nicotine level in the blood drops to 0. 2 to 3 days, the carbon monoxide level in our blood drops to levels of someone who does not use tobacco. 1 to 12 months, up to a year, coughing and shortness of breath decrease. We look at a year to 2 years, the risk of heart attack drops sharply. 3 to 6 years, added risk of coronary heart disease drops by half. 5 to 10 years, the added risk of cancers of the mouth, throat, and voice drops by half. And then 10 years, the added risk of lung cancer drops by half. 15 years, the risk of coronary heart disease drops to close to that of someone who does not use tobacco. And 20 years, the risk of cancers, including pancreatic, drops close to that of a smoker, someone who does not smoke or use tobacco. And the added risk of cervical cancer drops by half. These are just key talking points that we're always continually using as we're guiding our tobacco user to keep them motivated and to be tobacco free. So now what I'd like to do is just give a few highlights about our service itself with the Illinois Tobacco Quit Line. As Gail referenced, this is a partnership that we have with the Illinois Department of Public Health, the Tobacco Control Program, along with the American Lung Association. We work collaboratively with Gail, who helps kind of steer us in the right direction and what we need to be doing. And she is always assessing her and her team as to where the strongest needs are. If there's a targeted population or targeted demographic, different groups that we should be targeting, it's always being brought up and how we can manage the services that we provide. But the Illinois Tobacco Quit Line was created back in 2001, and we're actually getting ready to celebrate our 20th year in providing the program. And the funds came through the Tobacco Master Settlement Funds. Also, we're really pleased, of course, with this free service. It's available to all residents in Illinois, and we assist in all forms of tobacco, including e-cigarettes and vaping. Our residents all residents in Illinois, 13 years of age and older, are able to receive counseling through our services. But as Gail referenced to you all, we are very pleased to also be integrating the My Life, My Quit program and being referring our teenagers to that. I talked about our core beliefs with tobacco cessation, and that is exactly what we tie into our services. Everyone can quit. You don't have to quit alone, and one size does not fit all. When you think about quit lines, there is a quit line in every state. And the studies show that 3 to 5% of people who can quit tobacco, they can quit without any form of assistance, the cold turkey quitting. Quit lines double the chances of quitting, and quit lines who offer nicotine replacement therapy triple the chances of quitting. I'm very pleased to say that effective January of this last year, we have been able to offer combination therapy per IDPH for nicotine replacement therapy. We offer patches, gum, and lozenges, and we also offer it twice a year. I'm going to go into that here momentarily, just so you're all aware. We have so many partners who work directly with the Illinois Tobacco Quit Line and IDPH, but we want to continue to enhance that. And I hope that with your organization and the organizations that each of you work for, that we would also look into partnering with us. I'm pleased to say, Nicole, that Northwestern is one of our strong partners that we work with. And actually, it started 2 days ago where they initiated our direct referral program into their EMR system. So that when they are doing assessing, when they are talking, of course, to their patients throughout the entire Northwestern Medicine program, they are referring to the ITQL.
Oh, thank you so much for sharing that.
And so we have multiple options and different ways for individuals to be able to connect to our quit line. So of course we have the phone number 866-QUIT-YES, but we also have live online chat available through quityes.org where they can talk to our counselors. And then we have a direct referral program, whether it's a traditional fax, whether it's an email, or through EHR with bidirectional communication. We try to give as much access as we can for the callers. We also try to be available as often as we can. So over the years, especially over these 20 years, we've definitely determined when the best times to be and when to amp up on our counseling staff. So we are here for Monday through Friday, 7 a.m. to 9 p.m. and also on the weekends from 9 to 5. Again, trying to be available to those so that, no excuses to say, well, they're not available during they're not available in the evening or not available on the weekends, but we are. Our languages, we have bilingual staff, but we also have an interpretation service that we work with over 250 languages. And also for telecommunication line for our individuals who are deaf or hard of hearing, we have that set up as well. I'm very pleased to say that our counselors who work through the Illinois Tobacco Quit Line are certified tobacco treatment specialists, and their training has been through Mayo Clinic, the Nicotine Dependence Center. And we also continue our training as there are new forms of tobacco, new forms of nicotine that come out. We are always continuing to stay abreast of all of that. The Illinois Tobacco Quit Line also has very targeted marketing campaigns and outreach that we do for special populations. So we look at those who have mental health conditions. We look at those with the lower education level, pregnant women, our LGBTQ communities, our teens, and our rural populations. I'd like to kind of take you all through what is the caller experience and what traditionally happens when someone reaches out to the Illinois Tobacco Quit Line. Well, first and foremost, we let the individual know that their first call can take approximately 30 to 45 minutes. We really are doing an assessment of questions. There's a little over 100 questions that we're gathering, just whether it's demographic information, health information, basic call information, health insurance information, and also just looking at how long they've been using tobacco, what forms of tobacco do they use, just continuing to gather as much information so we can develop a personalized quit plan. We do not have the same plan for everyone. It really determines on the amount of tobacco that they use, if they're are they dealing with chronic disease, and are there other challenges they may be facing, and how we can work together to build that individualized plan. We focus in on the reasons for quitting, their quit attempts. Are they dual usage, which we're seeing more of that with individuals who might not be able to, smoke, so they're using their vapes and other forms of nicotine. We also are determining if they have already quit and what was successful at that time and what made them slip or relapse, and how we can work on that. We talk about different quitting methods, and when we really look at their level of confidence of quitting, that's really going to help build a strong plan. We also look at nicotine dependence. We're doing an assessment to, again, look at the current tobacco use, how long they've been using it, what products they're using, are they dual users, how often are they using it? And we also track and really determine at what time of day that they're using it. And that, again, helps us kind of develop a plan as we look and build for their future. And then we're also using this time to determine which nicotine replacement therapy might be best. And we look at all the 7 FDA medications that we're guiding on. Although the Illinois Tobacco Quit Line is able to provide patches, gum, and lozenges, our counselors are also determining that maybe those 3 products aren't what works best, but also looking at the prescription and also the inhaler and nasal spray, and finding what's going to work best for them. It's very, very important for us to note is electronic cigarettes, e-cigarettes, and vaping is not an FDA approved NRT and should not be recommended for tobacco cessation. Although you'll hear commercials for many of your vape stores and your billboards that are out there where they will be talking about the importance of using e-cigarettes in your quitting process. So we just like to make sure we state that. So one of the things we had referenced is that we do provide free nicotine replacement therapy, and we do have eligibility. So individuals that are not eligible right now are those under the age of 18, those who are pregnant, those who may be medically contraindicated with using NRT, those who are on Medicaid, and I'll explain that here momentarily, and also those who have private insurance that is already covering those products. In reference to Medicaid, what is important to note is they have a wonderful resource where it provides 90-day supply twice a year for Medicaid individuals. So our counselors just kind of remind those recipients and let them know this is how the program works. You're able to get counseling through us, but you can get your medication through your provider. And we remind them of the process and what they need to do. As we said, the NRT products are available, and we provide 8 weeks supply. And it's important for you to note that we don't give 8 weeks all at once. We are assessing. We are holding each of our callers accountable. So what we are asking is we provide 2 weeks supply based on what's going to work best for them. And the reason we say 2 weeks at a time is we're also asking each of our callers to call us weekly. We either set up proactive calls or they will reactively call us each week. So we give them the option. And we recently added that we're able to do this twice a year. And we're pleased with that because what we do is at our 7-month follow-up call, and if for any reason they haven't remained tobacco-free and they are still challenged, we can enroll them again right at that time. So what happens after the initial call? So we ultimately will develop a method that's going to work best for them. As referenced, we either set up a reactive or a proactive approach. We also send out, whether it's by email or regular mail, a quick kit that really ultimately has self-help materials that are very personalized, that will assist them. And it's kind of a reinforcement of what our counselors are guiding the callers to do. So they're hearing it, but they're also being able to read it and view it. An average caller, we find, is going to call about 4 weeks, but we do encourage for them to do that longer if it's needed. Sometimes it's not. And then we also provide follow-up. We do a 7-month assessment and determine if they are tobacco-free and to track their quit status. And this is something that all quit lines do. And our quit rates have It ranges at times because it's self-reported. You know, we do our best to be able to reach out to all callers and get a response to check on them. But currently, we're just a little over 30% with our quit rate right now. Also important for you all to know that if you would like any promotional materials, we have rack cards, business cards, tear-off pads, tent cards and posters available in English and Spanish. You can get the order form through quityes.org, or you can certainly reach out to one of us here. This is the contact information for myself as well as Gail. And I know, of course, if you would like to share this presentation, you certainly can, Yvonne, to your members. But we really want to stress that we're here, a free service available, and we want to encourage everyone to promote it, as well as if you are someone who is in need, that you feel comfortable and confident in calling for our service.
Thank you very much. I'd like to thank my partners for the evening, Nicole Hunt, Gail DeVito, and Lori Yunker. We do have a few questions, but before we get ready to take questions, in the link now, there is in the chat box now, there is a link for a survey. We would really love for you to click on that link, go down to the engagement survey and give us your opinion. This is our first month back for this calendar year, and we will be doing 2 events per month until June. We want the community to be involved. We want our partners to be involved. So you're answering those questions on the survey only helps us get better. So please take a moment to fill out that survey. We do have a few questions. The first question, actually, Laura, you answered. There was a question related to some literature that says transition patients to e-cigarettes as they're transitioning off of real cigarettes. So you answered that, and I really want to echo that that's really not encouraged. You substituting one substance for another. So thank you for answering that. The next question relates to why is secondhand e-cigarette exposure so significant? And I'll let either of you take that.
Sure. So Gail, do you want, or I can?
Okay, I'll just talk about, we can both, I will talk about the just the unknown. We don't know. They've already identified there are a lot of chemicals in e-cigarettes. They're maybe not as many as cigarettes, of course, not as many as cigarettes. There aren't very many substances that we know of that are more dangerous than cigarettes. So comparing it to the dangers of cigarettes is a very low bar, because cigarettes contain 7,000 hazardous chemicals, and there's just not enough known about e-cigarettes, but there is more known as we go along. In 2015, there wasn't much known, but now there is. So exposure to e-cigarette vapor is dangerous in itself. And you can add more if you'd like, Lori.
Sure. Well, what I wanted to do is I actually posted a couple of links in the chat. It goes specifically to talk in 2 areas regarding the Surgeon General's report, and it was focused on, of course, kids at that time, but ultimately letting us all know that yes, there are emissions that contain harmful chemicals, but I think we also know, as Gail referenced, it's still non-regulated. And even though we've got legislation, things are passing, and the FDA knows it's part of what they need to be doing, we still have a ways to go to where we can really understand. Just like it took us how many years to finally find out about tobacco use and secondhand smoke. So now I think we all still have to have that. Still have to wait, but hopefully these articles will be very helpful too.
Thank you. So everyone, going to the chat, there are 2 articles, so make sure you click those links and download those before you leave us tonight. The next question was Juul versus e-cigarette. Are they the same? Are they different? Is one better than the other? Who wants to take that on?
I'll take
yeah,
that.
Go for that.
Yeah, Juul they're considered an e-cigarette. They're young people call them Juuls. They call it juuling. They don't say they're smoking, but they are considered an e-cigarette, and they contain nicotine, and they one Juul pod contains the same amount of nicotine as a pack of cigarettes, and that's why young people became addicted so quickly with Juuls. They're a different form of nicotine too. Cigarette, combustible tobacco uses freebase nicotine, and Juuls and other of the pod type vaping products use nicotine salts, and the nicotine salts have a faster delivery of nicotine to the brain, and young people have become addicted to Juuls very quickly. And what we've been hearing from the team at My Life, My Quit is that the young people who contact them are genuinely concerned because of their addiction, and they want to quit. So the ones who have become severely addicted very quickly and didn't expect that to happen are very concerned for their health, and they don't want to be addicted.
Absolutely. If there are other questions, you can put it in the chat. The last question revolved around secondhand smoke, and if there's anything else that the community can do related to advocacy to decrease the exacerbations of asthma, especially in lower income communities.
In multi-unit housing. And there are, we can connect you with coalitions. I don't have information ready to put in the chat now, but I can send you information. We have a state coalition. We have Chicago. I'm not sure how active, a lot of the coalition work has been sidetracked over the past year and a half. That's true. Tobacco has taken a back seat to, everything has taken a back seat to COVID. And so these coalitions, our community, our partners are working to rejuvenate coalition activity, and so are we at the state level. So I will provide you with information, and when we are going to convene, when we convene the state coalition, we're convening it around a particular issue, like multi-unit housing is a huge issue. We are just, we receive calls on our hotline every week and about it, and about, people in an apartment complex who have, and they talk about a child with asthma, and we can't tell them, yes, we will have it inspected by your local health department, because it's outside of the Smoke-Free Illinois Act. So, but I will send you some information, Dr. Collins.
Great, thank you. Thank you all again for attending this evening. Feel free to join us for our second October event on Saturday as we close out October, which is Breast Cancer Month. Do I have a DREF representative on this evening that wants to close us out? I don't see anyone. Well, thank you all very much on behalf of the Delta Research and Educational Foundation. Research matters for all of us. Please continue to join us monthly for our events. And I hope you gained one nugget tonight that you did not have prior to joining us. Again, thank you to our speakers and all of you. Have a great evening and stay masked up. Thank you.
Thank you.
Thank you.